Hi, my name is Boris Malyugin. I'm from Moscow, Russia, and I will be happy to share with you my experiences with pupil management in cataract surgery. First of all, a little bit about myself and the institution. So this is the Fyodorov Eye Microsurgery Institution, as shown here, and you actually see the main building. We have an educational facility. We have polyclinics and place where our patient can stay short term. Actually, we have the major facility in Moscow, and also we do have affiliations all over Russia. And as shown here, this is the European part of Russia, which is much more populated than the Asian one. And we see that the biggest number of clinics we do have located is in the European part of the Russian Federation. And this is how these clinics looks like. There are 10 of them, including some smaller outpatient clinics all around. Talking about cataract surgery, we need to keep in mind several critical aspects of that surgery. We need to talk about optimal instrumentation and settings. We need to talk about proper surgical maneuvers and visualization, capsular stability and keeping capsular integrity. And of course, I will design and fixation methods. So there are many of them to be kept in mind. However, I will focus today on visualization, which is one of the major things in cataract surgery to be discussed. Visualization is very much decreased when we do have problems with corneal transparency, but also the other major factor is the size of the pupil, as shown here. Very small pupil does not allow us to visualize what's going on behind the iris and does not give us a good access to the lens and to the lens capsule and the capsule content. So, and for years, it was a big issue for cataract surgeon and even for the ancient cataract surgeon. And as you can see here, iridectomy was one of the options at that time to have a good access to the lens to be able to extract it from the eye. Later on, pharmacological substances were used. One of them is belladonna, or as we know it, atropine, and it was introduced to ophthalmology by Carl Gustav Himmler in his seminal work, which was published in 1831. Small pupil is not only a geometrical issue, also an indication of various systemic and local comorbidities, because it is very much associated with zonular pathology, blood aqueous barrier disruption, IOP spikes, and so far and so on. And it is also known for its association with the increased complication rate, such as iris trauma, capsular rupture, vitreous loss, inflammation, etc. And it is known that 1 millimeter of pupil, which is abnormal, subnormal, so the 1 millimeter of pupil meiosis increase the complication rate by roughly 10%. There are several techniques that can be used to manage small pupils in cataract surgery. I do think that stepwise approach is the most logical and appropriate one. We start with, of course, topical mydriatics, but also we follow with the intracameral injection of phenylephrine or epinephrine into the anterior chamber, following by viscodilatation, because we know that the deepening of the anterior chamber actually increases the size of the pupil. After that, posterior synechiolysis can be done if posterior synechia exists. And if the pupil is fibrotic, we need to stretch it in order to expand it, and then we need to decide about pupil expansion rings and hooks. Intracameral mydriatics are very effective, as shown here. Right after intracameral phenylephrine injection, we see that the pupil starts to open, and we have a very nice size of the pupil. And this is another case of a patient with pseudoexfoliative syndrome, and is shown here. The pupil starts to open, but at some point it stops, and we don't have a good access, and we don't have a good pupil dilation, and we don't have a good access to the lens. Intracameral mydriatics to be used are 1% phenylephrine, or combination of phenylephrine and lidocaine. And in Europe, there is a Midrain, which is a combination of phenylephrine, tropicamide, and lidocaine, which is injected intracamerally. And also there is another option of utilizing combination of phenylephrine and non-steroid anti-inflammatory agent, which is delivered to the anterior chamber by continuous irrigation throughout phacoemulsification procedure. And this is the publication showing that we can not only sustain the pupil dilation during the surgery, but also decrease the postoperative pain. However, it is to be mentioned that the pupil is very small at the very beginning, so this pharmacologic combination will not give you pupil expansion. It gives you just sustainability of the pupil size throughout the procedure. As already mentioned, posterior synechiolysis is one of the options, and usually these synechia are very loosely attached to the anterior capsule, as shown here, and it's quite easy to break them with the side port instrument, and with this maneuver, pupil expands. The other option is to utilize peripupillary membranectomy, and this is the pupil stretching technique when we use two instruments and stretching the pupil in the opposite sides. And by doing that, we sometimes are being able to see and to visualize the pupillary membrane, which is attached to the posterior surface of the iris. And then by removing that membrane, either with micro capsulorhexis forceps or specially designed forceps, it's possible to release this membrane, which is constricting the pupil. It does not allowing it to expand. And then after removing that membrane, it is possible to have much better pupil dilation. And of course, you may see there is some bleeding from the pupillary margin happening here. However, this is usually not very significant and can be blocked by viscoelastic or increasing the pressure in the anterior chamber. Sometimes pupillary membranes are so intense that you're having troubles finding a good spot to introduce the instrument into the posterior chamber. And also this bimanual technique is quite useful by holding the membrane with the right hand and stabilizing the iris with the left hand. I'm helping myself to remove this membrane away from that iris. One of the options to get rid of the pupillary membrane is fragmented with micro scissors, as shown here. This is a 25 gauge instrument that is introduced through the main incision, and we can also introduce it through the side port incision and from different angles in order to cut this membrane. This is a membrane which is now being fragmented with the help of the scissors, and again by cutting this membrane into pieces, it's possible to remove this membrane more or less successfully. There is another option which is shown here. Actually, we see here a very thick fibrotic membrane, which is about 1.5 to 2 millimeters wide. And in order to expand the pupil, we need to reach this area of relatively elastic tissue. And for that, we need to cut all the way through that membrane in order to get this significantly fibrotic tissue to be broken in several pieces. And then by that, it's possible to expand the pupil. And of course, when we are cutting the iris tissue, what we can expect is bleeding as shown here, which can be managed by diathermy of the iris vessels. This is another option, which is a mechanical pupil dilation. Iris hooks are widely utilized for that purpose, and is shown here by holding the iris in 4 points. We may have a very nice square pupil, allowing us to have an access to the lens material, allowing us to stabilize the pupil. We have to keep in mind that we don't have to overstretch the pupil or overexpand the pupil, because at the final moments of this expansion, the iris, as shown on this cross-sectional image with OCT, the iris is lifting now above the plane of the anterior lens capsule, and with that you may have difficulties with introducing instruments into the anterior chamber. This is another great instrument, which is a capsular hook, especially designed for the purpose of not only expanding the pupil if necessary, but also to keep and support the weakened zonial apparatus, as shown here. So the edge of that device is resting on the equator of the capsular bag, and there is a gap in between the tip of that device and the anterior capsule. So there is no stress on the anterior capsular axis edge, and there is no chance that the membrane will be, that the capsule will be ruptured by rhexis radialization. So this is how these devices work. And again, you see that the pupil was not perfectly wide. However, now we are expanding the pupil and at the same time supporting the capsular bag and supporting missing zonials, and having a double effect of expanding the pupil and having a good support of stabilization of the capsular bag during the procedure. ASIA pupil expansion device is another option, as shown here. This is a scissor-like instrument that each of these instruments introduced through the paracentesis and catching the iris into points, and this is more or less similar to what we have with the iris hooks. However, it is much better because actually you reduce the number of incisions needed for this pupil expansion by a factor of 2. You need only 2 paracenteses instead of 4 in case of iris hooks. This is how the device works. It's a plastic disposable version of the APX 200 pupil expansion device, and you see that by releasing the spring, the branches of that device with the hooked elements catches the pupillary margin, and you have very nice square pupil at the end of the procedure. However, we don't like square pupils. Why is that? And the question and the answer is quite simple, because given the same size of the pupil, this perimeter of the square is much longer than the perimeter of the circle. And that's why when we do have square pupil, there is always a tendency to overstretch the iris tissue. And this is where the iris rings come into place. There are several pupil expansion rings that were being introduced during the course of the history of cataract surgery: perfect pupil, greater ring, and some others. Most of them sharing more or less the same concept of having fixation element on the outer side of the ring that catches the iris margin and hold the margin in place. So this is the device that I introduced into clinical practice more than 10 years ago, which is based on the concept of the circular elements that are located in the corners of this device. And these circular elements are coming from the lens that we were using for many years in Fyodorov institution. That was a rigid PMMA lens that was used for extracapsular cataract extraction. And actually this principle was quite successfully used by us for catching the anterior capsule and using the anterior capsule for fixation of intraocular lens. And then finally, we came up to the concept of the pupil expansion. What is good with this device is that actually, in spite of the square shape, you actually have 8 points of iris fixation, because there are, in addition to the fixation points that are located at the corners of the device, there is one more point in the middle when the thread goes from the upper portion of the iris to behind the iris. So it's actually equals to 8 iris hooks, and that is why the pupil is almost round rather than being square, which you may expect from the square shape of that device. And we were partnering with MST to produce these nice devices, which are having different sizes, 6¼ and 7 millimeter, and special holder, and the special injector that are used to insert and remove the ring in and out of the eye. As shown here, this is the injection process, and the ring expels from the injection device, and at the same point catching the distal and 2 side scrolls with the iris. And then what you need to do is to engage the last scroll, proximal scroll, which is located closer to the main incision, and then place the device properly and center it. So removal is also quite straightforward. You just disengage the distal scroll located contralaterally to the main incision, and lift a little bit the proximal scroll above the iris plane, and then catches this scroll with the hook of the injector device, and then retract it inside the injector tube, as shown here. And at the end of the procedure, you can see that the pupil become constricted again. It's very nice and round. So there were several improvements and modifications, such as Osher-Malyugin ring manipulator, especially designed thinner hooks that allows us to more reliably insert and remove the device from the eye. And actually, my personal preference is a small ring, especially with very small and fibrotic pupils. However, for intraoperative floppy iris syndrome, I do believe that the bigger one works much better, and as well as for the surgeon preferring divide and conquer or phaco flip rather than phaco chop procedures. First publication on the Malyugin ring was by David Chang, who showed that it is quite useful in intraoperative floppy iris syndrome, which I will be talking a little bit later on. Is shown here. The pupil is not very small, but actually we can see that the iris going through the main incision, and it is incarcerated into the paracentesis, and you anticipate some issues to be happen here. And this is one of the clinical cases showing how the pupil starts to constrict throughout the procedure, and there is a propensity of the iris to prolapse into the phaco and side port incisions, and this is a progressive pupillary constriction during surgery, and the billowness of the iris, which is fluctuating under the irrigating currents. And obviously we need to do something here in order to avoid complications and issues in that case. And this is the iris now being repositioned with viscoelastic introduced through the main and side port incisions, and you can see that the pupil is quite small and very flaccid here. So this is another clinical case when the femtosecond laser assisted capsulotomy and lens fragmentation was being done. And again, we started with a relatively decent size of the pupil at the beginning of the procedure. However, as we are proceeding with the phaco emulsification, the pupil is now progressively constricting, and again we see that there is some billowing of the iris, which is having a tendency to go into the main phaco needle, to the phaco needle, and we have to be quite cautious of not catching the iris in that case by irrigating, aspirating it into the phaco needle, as shown here. The reason for that syndrome is the the use of antagonists of alpha-1 adrenergic receptors, such as tamsulosin or Flomax, that changes the dilator smooth muscle anatomy, as shown here. This is a normal thickness of the dilating muscle, which is taken from the cadaver eye, and this is the thickness of the muscle dilating the pupil from the subject taking tamsulosin, and we see that there is a marked thinning of that muscle. And there are some other mechanisms involved, including the degradation of the nucleus that are shared in between the dilator muscles and the pigment epithelium, which was shown on the experimental model. And the result of that is quite devastating. As you see here, in a retrospective study, it was up more than 12% of complications, and some of them quite significant, with
partial loss of iris tissue, giving quite significant functional and also cosmetical result. And the question is, can we anticipate intraoperative floppy iris syndrome? And the answer is yes, because when we do have pupil which is initially suboptimal on the patient having tamsulosin, so there is almost fourfold increased chance of having intraoperative floppy iris syndrome as opposed to the person having very wide and well dilated pupils. So by judging the size of the pupil preoperatively and intraoperatively, you can actually anticipate this intraoperative floppy iris syndrome to happen. And the other question, whether intraoperative floppy iris syndrome is associated with medications used for benign prostatic hyperplasia, and as you can see here, intraoperative floppy iris syndrome was observed in 12.6% of cases. However, there was a substantial amount of female patients showing that syndrome that are obviously not taking tamsulosin, and this is another paper showing that intraoperative floppy iris syndrome is obviously higher with men. However, it can also be seen in women as well. The prevalence of that syndrome with men is almost five times bigger than in women. Why is that? Because there are some other medications involved, which is the ones that are used for arterial hypertension, that are having angiotensin II type receptor blockers, and also with some medications used for anxiety disorders. They are also associating with that syndrome. As shown here, there are several drugs that are associated with this syndrome. However, not all of the patients are having any kind of drugs. There is a substantial amount of patients that are not using any kind of drugs, and this, of course, may happen with them. From my point of view, intracameral injection of mydriatics is the way to go, and these are two already mentioned in description of the stepwise approach, as you may see here. The other option is to use the mechanical pupil expansion devices. This is the patient with intraoperative floppy iris syndrome, and as soon as the viscoelastic left the anterior chamber, you see that the iris become billowing under the irrigation currents, and pupil starts progressively constricting and prolapsing through the side port incision. And obviously, to be on the safe side, we need to do something such as use the pupil expansion ring. And as shown here, as soon as you insert viscoelastic, you see that the pupil become quite big again. So you may expect that with the smaller ring, you will not be able to have a good hold of the iris. So this bigger one is the 7mm ring is much more useful in intraoperative floppy iris syndrome. And in fact, in spite of the minor depigmentation of the area corresponding to paracentesis, this case was completed quite successfully. And of course, good innovations always stems at other innovations, and shown here, there are several other pupil expansion rings that are currently available on the market. First to be mentioned, one that is from India. This is 5-0 nylon with indentations used to catch the iris tissue, and this is a planar structure, and this with the latest hexagonal version with positioning holes that are helpful to manipulate the device, insert and remove it from the eye. Nitinol wire, which is a thin metal wire, can also be used for that purpose, and is shown here. This is the three-dimensional structure that is used to insert, that is used with the special insertion device, as shown here, and it is now injected inside the anterior chamber, and the instrument, such as fork-shaped spatula, is used to catch the iris with the fixation element of that device, and as a result, we have 7 millimeter square, almost round pupil, and you see how this device can be removed from the eye in a manner opposite to what you've just seen in the previous video clip. So you use the instrument, disengage the device from the iris with the positioning elements one by one, and then you may use forceps or use the same injector that was used for introducing the ring into the eye, catch the one of the sides of this ring, and then remove that device from the eye, as shown here in that video clip. Although not all devices are similar, and you have to keep in mind that the profile of expand is slightly bigger than that of the Malyugin ring, and you have to keep in mind that while manipulating it inside the anterior chamber. So this is another device made of soft polyurethane, and again, it can be used with injection system, and these are triangular side port elements, the triangular corner elements that are used to engage with the iris tissue, having special holes, and you can utilize Synechiolysis hook in order to catch the iris with the corner elements, and actually you can use the same injector device in order to insert remove the eye ring from the eye. This is another made from polyurethane Oasis iris expander, and which is shown here. And again, it utilizes the special pockets that are used to engage with the iris tissue. Malyugin ring 2.0 is the newest version of the pupil expansion device, having thinner thread, 5-0 polypropylene, also a new injector and new holder that are being utilized here. Basically, the technique of insertion and removal are quite the same. This is 2.0 version, 7 millimeter in size, and as you can see here, it is easy to insert and remove with more or less the same technique shown for the classical version. And actually, you can use this injection device to remove the expansion ring from the eye, and as soon as the viscoelastic is removed from the eye, you see that the pupil regains its shape and size. What is good is that the thinner thread gives us a much better flexibility. There is much less force needed to compress two ends of the device, and also by utilizing thinner thread, we increase the gap that is shown here, so it's much easier to remove. Both versions, I think, should be in the surgical armamentarium, because thicker classical version is better to use with a very small and very fibrotic pupils, and 2.0 is indicated in moderately dilated pupils or patients with floppy iris syndrome, when there is no need to forcefully open the pupil, because the pupil easily goes back and forth during the course of the procedure. So I do believe that with the latest advances with ocular pharmacology and new pupil expander devices and designs, we should be happy with the options currently available for small pupil cataract surgery. And I thank you very much for your kind attention.